Welcome to the presentation for Module 11, Nursing 150. This presentation will look at Alzheimer's disease and Parkinson's disease. We will discuss the presentation, causes, treatment, nursing care, and patient and family education regarding these two disease processes. This is just a review slide to just kind of revisit the anatomy and physiology of the neurologic system. Remember, there's a central nervous system which consists of the brain and spinal cord. The disorders of Alzheimer's and Parkinson's affects the central nervous system. The disorder is centralized within the brain for both disorders, and so that's where these disorders are located. The peripheral nervous system consists of the peripheral nerves. The peripheral nervous system includes the peripheral and cranial nerves. Peripheral sensory nerves transmit stimuli from sensory receptors in the skin, muscles, sensory organs, and up to the upper part. The upper motor neurons of the brain and the lower motor neurons of cell bodies and the ventral horn of the spinal cord carry impulses that affect movement. Just looking specifically at the brain, since these two disorders of Parkinson's and Alzheimer's are disorders that are centralized in the brain, just kind of reviewing the brain itself, it consists of three major parts: the cerebrum, the brainstem, and the cerebellum. It collects, it integrates, and interprets all stimuli. In addition, it initiates and monitors voluntary and involuntary motor activity. The cerebrum has four significant lobes: the parietal, the occipital, the temporal, and the frontal lobes. The cerebrum is also divided into two hemispheres. The right hemisphere controls the left side of the body, and the left hemisphere controls the right side of the body. Each of the four lobes that were mentioned controls and coordinates specific functions. This is just a picture of those four lobes. And just to kind of review that different parts of the brain are responsible for different activity, and then it also is a review here of where the brainstem is and where the cerebellum is and what functions they are responsible for. Alzheimer's disease is a type of dementia. It typically is referred to as early dementia, Alzheimer type, or pre-senile dementia. It's typically because it occurs in people 40 to 50 years old. It is a progressive neurologic disorder that affects the brain and results in cognitive impairments such as impaired thinking, memory loss, and bizarre behavior. Alzheimer's disease is the most common form of dementia and is the fourth leading cause of death in adults. The cause of Alzheimer's disease isn't known. However, several factors appear to have some association with the disease. These include deficiencies in neurotransmitters acetylcholine or norepinephrine, repeated head trauma, abnormalities on chromosomes 14 or 21, and deposits of beta amyloid protein. So again, this slide is saying we don't know the exact known cause. We know some things that appear to be associated with the development of Alzheimer's disease. It has been well established that family history and gender are important risk factors. It appears more in women than men. There are several other theories that think that environmental agents, especially certain viruses such as herpes zoster and herpes simplex, and toxic metals such as zinc and copper have been suggested as causes for Alzheimer's disease. Discussing what to look for as far as the assessment in a patient with Alzheimer's disease. Often the onset of Alzheimer's disease is a little bit puzzling. Initial changes are almost imperceptible, but gradually progress to serious problems. Initial signs and symptoms often include forgetfulness and short-term memory loss, difficulty learning and remembering new information, deterioration in personal hygiene and appearance, inability to concentrate. And this is, as you can imagine, this onset, these can be easily mistaken for just getting older, especially just forgetfulness and short-term memory. And there is to some degree, that is expected in an older person. But these are, like I said, that's why sometimes the onset is almost imperceptible. The later signs and symptoms, though, become more easy to detect, and these later signs and symptoms of Alzheimer's typically include difficulty with abstract thinking and activities that require judgment, so they have like poor judgment. They continue to have difficulty communicating, severe deterioration in memory, language, and motor function, repetitive actions, nocturnal awakening, disorientation, and personality changes are the later stages of Alzheimer's disease. As far as some of the brain tissue of patients with Alzheimer's disease, they exhibit three characteristic features. They have neurofibrillatory tangles, which are bundles of filaments and neurons that twist abnormally around one another. They're most numerous in the areas of the brain associated with memory and learning. It's important to note that these neurofibrillary tangles are a classic finding at autopsy in the brains of patients with Alzheimer's disease. It's almost impossible to see these while the patient is alive, and so the definitive diagnosis of Alzheimer's disease cannot be made until the autopsy has been performed. But basically, if the patient meets all the criteria as far as early, middle, and late stages of Alzheimer's, they will go ahead and diagnose them with that. But it isn't until the patient is deceased and that we do an autopsy that we can really see specific proof that that's what it is, specific data, until we do an autopsy. All the stages of Alzheimer's are listed in your book as key features for each stage. It's important to review those just to become familiar with, maybe to be able to identify signs of early onset so that that patient can be identified and treated and educated appropriately in the early stages of Alzheimer's disease. Some of the first signs of Alzheimer's include short-term memory impairment, also changes in cognition. Cognition meaning the ability of the brain to process, store, retrieve, and use information. Therefore, the patient will begin to show deficits in attention and concentration, judgment and perception, learning and memory, communication and language, and speed of information processing. We have assessment tools such as Folstein's Mini Mental State Exam to help us identify any of these deficits in cognition or short-term memory. Folstein's Mini Mental State Examination is also known as the Mini Mental Exam. It assesses 5 major areas: orientation, registration, attention, calculation, and recall, and speech and language. So it's been used widely to be able to identify whether a patient is showing any of the stages of Alzheimer's disease. And usually this is done on a patient who has come in and maybe their family has expressed that they're concerned about their behavior, their memory, or speech, things like that. And so the mini mental exam can help identify if indeed there are some deficits or it's just something that somebody is imagining. Oftentimes, towards the later stages of Alzheimer's disease, the patient will present with very significant changes in their behavior and personality. This can be difficult for the families because sometimes it can be the sweetest person that in their younger age was very sweet, very kind. They can become aggressive verbally and physically, have rapid mood swings, and have sundowning, which is increased confusion at night or when the light is not adequate. The patient may wander and become lost or may go into other rooms to rummage through others' belongings, hoarding, things like that. And this could be a huge change in a patient's behavior. It's something that they never did before in their life, and so this is difficult for caregivers to kind of cope with such a change in the patient's behavior. As you can imagine, when the patient is exhibiting some of these aggressive behaviors, these rapid mood swings with wandering and sundowning, safety is a big fear that they could get injured. Plus, if they're having difficulty with memory, they don't remember where they are, who they are, things like that, it can really lead to a safety issue. As with most of the other neurological disorders, any patient displaying any change in their cognition, their memory, any change in behavior, we will always rule out any kind of other disorder before looking further and calling it Alzheimer's disease. Things such as hypoglycemia, brain tumor, brain swelling, stroke, things like that can the patient can experience some memory loss, and personality disorders. Metabolic disorders can cause such a thing, so it's always important to rule that out, because if we can identify that maybe it's a brain tumor, maybe we can treat the brain tumor and have the patient's symptoms will decrease. So lab assessments are often initially targeted at ruling out other things. There is no lab test to definitively diagnose Alzheimer's. Definitive diagnosis is made on the basis of brain tissue exam at autopsy, which confirms the presence of the neurofibrillary tangles that I mentioned before. Genetic testing, there is a specific gene called apolipoprotein E4, known as APO4, may be helpful as an ancillary test for the differential diagnosis of Alzheimer's disease. There are many other labs that might support the diagnosis of Alzheimer's disease, but again, it does not give a definitive diagnosis. And again, some other labs might be done to rule out other treatable causes of dementia or delirium. Urinalysis, CBCs, blood ammonia levels, thyroid and liver function test, alcohol screening tests, things like that. CT scan, MRI, PET scan, EEG, all again to rule out any other treatable causes for the change in the patient's presentation. Moving into nursing care of a patient with Alzheimer's disease. Again, it depends on the stage that the patient is in. The more advanced the stage of Alzheimer's, the more issues are going to occur. The priority for interdisciplinary care is safety. Chronic confusion and physical deficits place the patient with Alzheimer's at a high risk for injury. It's important to establish an effective communication system with the patient and their family to help them adjust to the altered cognitive abilities. Protect the patient from injury by providing a safe, structured, and supervised environment. And encourage the patient to exercise to help maintain mobility. Refer family members to appropriate social service agencies that can help the family assess its needs. Evaluate the patient. They should be free from injury, have an established adequate sleep pattern, and have adequate nutrition. Assess the patient's family to determine if they have sufficient support systems to help them cope with the crisis. Encourage the patient and their family to express their feelings of loss. Sometimes the change in the patient's behavior can make the caregivers feel like they really have lost a loved one. Although drug therapy may be used for patients with dementia or Alzheimer's disease, non-pharmacologic interventions are the main focus of collaborative management of it. Teach family members and significant others about the importance of being consistent and following the plan of care. Always consider that the patient with Alzheimer's often has other medical problems, such as cardiovascular disease, arthritis, renal insufficiency, and pulmonary disease. Changes in vision and hearing may also be present. Managing these conditions helps the patient's functional abilities. Approaches to managing the patient who has Alzheimer's disease includes cognitive stimulation and memory training, structuring the environment, orientation and validation therapy, promoting self-management, promoting bowel and bladder continence, and promoting communication is really big. It is important to keep all of this in mind when admitting a patient with Alzheimer's disease in a new setting or environment. It's important to keep the patient close if they are wandering, under close supervision, and with less stimulation, quiet, away from obvious exits if possible. Try to keep a structured environment with the same routine. Anything that kind of upsets them or causes them stress can make their dementia worse. So it's always kind of good to keep them on schedule and keep a routine. One thing to always keep in mind regarding a patient with chronic confusion is to make sure you maintain a clear path between the bed and the bathroom. Use the redirection by attracting the patient's attention to promote communication. Keep the environment as free from distractions as possible. Speak directly to the patient in a distinct manner. Sentences should be clear and short. Remind the patient to perform one task at a time. It may be easier to break each task down into small steps. There's a great table in your book called Best Practice for Patient Safety and Quality Care. It talks about how to deal with a patient with chronic confusion. It's best not to argue with them. You want to try to anticipate their needs and interpret nonverbal communications. Validates the patient's feelings. Use simple short sentences and one-step instructions again. So make sure you review those instructions. It's very key in the care of a patient with Alzheimer's. There are some drugs used in the treatment of Alzheimer's disease. Aricept is a cholinesterase inhibitor. They work to improve the cholinergic neurotransmission in the brain. Action of this slows the onset of cognitive decline in some patients. None of these drugs alter the course of the disease. They can just kind of decrease the symptoms. So in other words, we don't have a cure. We do have some medications that can help decrease some of the symptoms. Memetine is another one, also known as Namenda. It is the first new class of drugs that is low to moderate affinity. Memetine is indicated for advanced Alzheimer's and has been shown to slow the pace of deterioration. It may help maintain patient function for a few months longer. Some patients also have improved memory and thinking skills. So again, sometimes the drug can be given with, the Namenda can be given with the Aricept, which is the donepezil. Together, they can kind of help decrease the symptoms. One thing to note about donepezil is that it usually works better if it is started in the earlier stages of Alzheimer's disease. In addition, a lot of patients with Alzheimer's begin to have depression, and a lot of it's due to their decreased function in society due to their deficits. So some antidepressants and sometimes antipsychotic medications are in order due to some of the behavioral changes, the aggressive behavior, and the depression. So they're used in combination with these Alzheimer's medications. Again, we have no cure. These medications are not going to cure this disease, but it should slow down the progression. This is kind of a visual picture that shows what occurs in the brain due to Alzheimer's disease. Typically, it's an atrophy of the brain, which means it gets smaller. Autopsy commonly reveals an atrophic brain that can weigh 1,000 grams or less. A normal brain weight is 1,380 grams. So essentially what happens is the brain kind of shrinks and kind of becomes, as you can see how the difference between the healthy brain over here and the kind of atrophied brain in severe Alzheimer's disease. So that's why there's these, the decrease in the thought processes and the cognition due to the atrophy of the brain. The atrophy of the brain is thought to be associated with the neurofibrillatory tangles, amyloid plaques which occur. They're composed of degenerating axons and dendrites, and essentially just a deterioration of the brain is what's thought to occur at a young age, usually around 50 years old, which causes all of the neuro changes that you see in your Alzheimer's patient. The next few slides are some case study questions. I encourage you to go through and answer these questions regarding the care of a patient with Alzheimer's disease. The answers to the questions for the slides can be found in your PowerPoint in the comment section. I encourage you to try to answer them as you go along and then check your answers in the PowerPoint. Okay, the second part of this presentation will discuss Parkinson's disease. Parkinson's disease is a slowly progressive and degenerative disorder. It is one of the most common neurologic disorders in the United States. Parkinson's disease may appear at any age. However, it is rare in younger people, younger than the age of 30. The risk increases with age. It most commonly affects men. Parkinson's disease strikes 1 out of every 100 people older than the age of 60. The purpose of this slide is to help to understand the pathophysiology of Parkinson's disease. It's about the motor activity, how it occurs as a result of integrating the actions of the cerebral cortex, the basal ganglia, and the cerebellum. Movement is dependent on two major neurotransmitters. They accomplish the process of the basal ganglia being stimulated and muscle tone in the body is inhibited and voluntary movements are refined. All of this is dependent on the secretion of two major neurotransmitters that accomplish this, dopamine and acetylcholine. Dopamine is produced in the substantia nigra, as well as in the adrenal glands. It is transmitted to the basal ganglia along a connecting neural pathway for secretion when needed. The neurotransmitter acetylcholine is used as an excitatory message throughout the basal ganglia, so it excites things. Dopamine inhibits the function of these neurons, allowing control over voluntary movement. This system of checks and balances between the acetylcholine and the dopamine allows for refined, coordinated movement, such as picking up a pencil and writing. In a patient with Parkinson's disease, degeneration of the substantia nigra leads to a decrease in the amount of dopamine in the brain. When dopamine levels are decreased, a person loses the ability to that refined voluntary movement. This picture is showing basically where the deficit of dopamine occurs, that the movement is not as normal in the absence of appropriate amounts of dopamine. The exact cause of idiopathic Parkinson's disease is unknown. Few cases suggest a hereditary pattern. So there is a primary or idiopathic Parkinson's disease. That means we don't know what causes it. Secondary Parkinson's is a drug or chemical related Parkinson's, typically caused by dopamine depleting drugs such as reserpine, phenothiazine, metoclopramide. You don't have to know these meds, but just know that it can be secondary to a certain amount of medications that's caused the decrease in the amount of dopamine leading to Parkinson's disease. There are 4 cardinal symptoms as far as physical assessment of a patient with Parkinson's disease. These 4 cardinal symptoms are tremor, muscle rigidity, bradykinesia or akinesia. Bradykinesia means slow movement. Akinesia is referring to no movement. There are 4 stages of Parkinson's disease. Stage 1, of course, being the initial stage. Actually, it goes to 5 stages. Stage 5 being complete dependence in their ADLs. So stage 1 will be the initial stage, and then ranging from 2, 3, 4, 5 to the most severe stage of Parkinson's disease. We discussed the 4 cardinal signs of Parkinson's disease that you might find on assessment. And sometimes some of these symptoms the patient may ignore and just chalk up to growing older. Tremors are usually noticed in the upper extremities first and may increase with stress. Slow voluntary movements and reduced automatic movements may be manifested by a change in the patient's handwriting. The patient's tremor usually begins in the fingers, increases during stress or anxiety, and decreases with purposeful movement and sleep. Muscle rigidity that resists passive muscle stretching. Difficulty walking. They have, as depicted kind of here in this picture here, they have a short shuffling gait. And they sort of lean a little bit forward, this forward tilt to the posture. Also, just again, the rigidity and the tremors. The slowed speech. A blank facial expression, a mask-like, is very indicative of Parkinson's, where it's just kind of very expressionless. If you think maybe somebody who's had too much Botox, kind of looking face where it's very mask-like, very expressionless. Poor blink reflex and wide open eyes. Drooling and dysphagia become a problem. This means that a patient is beginning to have difficulty with swallowing. That's part of the muscle tone that is affected by the decrease in the dopamine levels. So they begin to have difficulty with drooling and dysphagia. It's interesting to note, if you look at your neurologic assessment, drooling in a patient is indicative of the loss of ability to swallow. So it's always important to note if you notice that a patient has excessive drooling. There are multiple key features of Parkinson's disease. It's important to look in your book at the table that lists all the key features. Among the ones that I've already discussed, a patient develops emotional changes such as depression, irritability, fear, and insecurities. They have changes in their speech pattern. Bowel and bladder problems are commonly seen in the Parkinson's patient due to malfunction of the autonomic nervous system. They exhibit typically urinary incontinence, difficulty urinating. They experience constipation, which can occur due to the slow motility of the GI tract because of poor dietary habits and poor fluid intake. The diagnosis of Parkinson's disease is made after the patient has been tested to rule out other types of neurologic diseases, specifically like a brain tumor, any virus, any infections, things like that. There are no specific tests that definitively diagnose Parkinson's disease. They may do a lumbar puncture and analyze the cerebrospinal fluid, which may show a decrease in the dopamine levels. Typically, drug therapy is utilized in the treatment of Parkinson's disease. Care for the patient with Parkinson's disease includes drug therapy, exercise program or physical therapy, strategies and collaboration to promote self-management, and psychosocial support. Ultimately, the goal of care is to preserve mobility, cognition, and quality of life. Drugs are prescribed to treat the symptoms of Parkinson's disease with the purpose of increasing the patient's functional abilities. An important desired outcome is to prescribe drugs with minimal long-term side effects. It is also important to remember the principle of management is to control the symptoms of Parkinson's disease because no drug or surgical approach prevents the progression of the disease. The drug levodopa, a dopaminergic agent, is considered the most effective anti-Parkinson's agent and has been shown to improve the symptoms of Parkinson's disease by 40 to 50%. Once it is started, the rule of thumb is to administer the lowest dosage that brings adequate symptom reversal. 90% of patients with true Parkinson's disease respond to the levodopa. Levodopa has its downfalls. Typically, after 2 to 5 years of treatment, more than 50% of patients experience fluctuations in their response to the levodopa. They may also experience dyskinesias, which means freezing, and mental and behavioral changes. Selagiline is an MAOI inhibitor and is considered a neuroprotective agent. It has fewer side effects than the levodopa, but the effect tends to only be moderate and provide inadequate symptomatic therapy, and thus typically is not used in monotherapy. There are dopamine agonists such as bromocriptine, pergoglide, and ropinirole, which is Requip. These are, they work directly on dopamine receptors. They do not require metabolic conversion. They are slightly less effective than levodopa, but are alternative first-line agents for Parkinson's disease. Anticholinergics, such as the drug benzotropine, are typically, they are centrally acting meds that have been used in the treatment for Parkinson's disease for a long time. They are typically used in patients age 70 or younger, and when the tremor is the dominant clinical feature, but in whom cognitive function is preserved. These agents are useful for treating resting tremors. However, adverse effects including memory impairment, hallucinations, and confusion are common with these drugs. Anticholinergic medications are rarely used alone, and they're not the primary drug of choice for Parkinson's disease. These drugs should also be avoided in older adults because they can cause acute confusion, urinary retention, constipation, dry mouth, and blurred vision. Patients who are on long-term drug regimen for Parkinson's disease often develop a drug tolerance or a toxicity. Basically, with a drug tolerance, the patient no longer has the effectiveness of the medication for the disease process of Parkinson's disease. When drug tolerance is reached, the drug's effects do not last as long. The treatment of Parkinson's disease drug toxicity or tolerance includes a reduction in the drug dosage, a change of the drug or in frequency of administration, or something called a drug holiday. During a drug holiday, it will usually last up to 10 days. The patient will receive no drug therapy for Parkinson's disease, which we will need to carefully monitor for symptoms at the time and document it. The drug will later be reintroduced in the hopes that it will become effective again for the patient's symptoms. All of this can be very confusing for the patient, so it's important that the nurse understands the drug therapy for a patient with Parkinson's disease and be able to teach them about it. Other medications that might be put into place are antidepressants or medications to treat constipation. Moving on to care of the patient with Parkinson's disease as far as nursing. Safety always is, again, a big issue. It's due to their poor gait, their muscle rigidity, their tremors, difficulty chewing and swallowing are big issues as far as safety. There's a chart in your book about best practice for patient safety and quality care. I would review that to make sure you understand all of the nursing responsibilities associated with taking care of a patient with Parkinson's disease. They include things like identifying a patient is in pain, monitoring their medication, educating about their medications, giving the patient extra time to complete their skills independently, schedule appointments and activities late in the morning to prevent rushing the patient. Nutrition is a big thing. You're going to want to provide easy to chew, high fiber nutrition. Small frequent meals to provide adequate nutrition. You should collaborate with a dietitian if needed to evaluate the patient's food intake and ability to eat. You may have to thicken their liquids in the event that they have difficulty swallowing so that they don't aspirate on thin liquids. Psychosocial support is important. The patient may have dementia and impaired cognition and memory deficits. This is difficult on the caregivers at times. Teach the family to emphasize the patient's abilities and strengths and provide positive reinforcement. Long-term management of Parkinson's disease presents a special challenge in the home care setting. There are some surgical interventions that can be done in the event that the patient it's a last resort when the drugs are not effective in symptom management. The most common surgeries are listed here: the stereotactic pallidotomy and the deep brain stimulations. Both of these are performed by a neurosurgeon and require specific treatment and monitoring. The stereotactic pallidotomy is the opening in the pallidum within the corpus stratum. It can be very effective treatment for controlling the symptoms. Brainstem stimulation is approved as a treatment for Parkinson's disease. They basically implant an electrode into the brain and connect it to a small electrical device called a pulse generator that delivers electrical current. The generator is placed under the skin, similar to a pacemaker. The generator is externally programmed to deliver an electrical current to decrease involuntary movement, known as dyskinesias. Again, these are last resorts if the medications are ineffective. Due to the high risk of infection due to doing a procedure within the brain. Again, this is just a visual reminder of all of the symptoms of Parkinson's disease that the patient may present with. Mask-like, again, and that kind of forward posture. And then all of the things listed on this side as the suggestions for the management of a patient with Parkinson's disease. Make sure you review these in understanding the care of a patient with Parkinson's disease. Following slide is just a question, just to test your learning and understanding. The answers to this question can be found in the PowerPoint in the comment section. I look forward to discussing this material with you in class.